This is the recording for Chapter 13, Neurocognitive Disorders. There are several different types of neurocognitive disorders, and we will look at those. The neurocognitive disorders are where there is a significant decrease in cognition or memory, and it changes the person's level of functioning. The objective of care for those with neurocognitive disorders is to provide those individuals with dignity and the quality of life that they deserve while offering guidance and support to their family and caregivers. First, we're going to talk about delirium. Delirium can happen to anyone. It is a mental state where there is a change in the level of consciousness and cognition. There could be short-term confusion, disorientation, excitement, hallucinations, or illusions. This can happen for a variety of different reasons. It can happen to the elderly, but it can also happen in young people. Here are some of the symptoms of delirium. They develop over a fairly rapid period of time. So difficulty sustaining and shifting attention, distractibility, disorganized thinking, speech that is irrelevant and incoherent, inability to reason, behavior that is not goal-directed, and being disoriented to time and place. Other symptoms include impairment of recent memory and misinterpretation of the environment, including illusions and hallucinations. If you remember, illusions is when something is there but you misinterpret what it is. Sleep-wake cycle problems. The person may be agitated, or they may be very stuporous or in like a vegetative state, and their emotions may change very quickly from irritability to depression to apathy to anger. Autonomic manifestations you might see with delirium include tachycardia, sweating, a flushed face, dilated pupils, and elevated blood pressure. Delirium symptoms usually start quickly. It is usually due to a systemic illness. It could also be due to a head injury or a seizure. The duration of delirium is usually a brief period of 3 to 7 days. Once you eliminate that underlying cause, the patient usually goes back to normal, but that does depend on the person's age and also how long their delirium has lasted. Delirium, in some cases, transitions to a more permanent cognitive disorder. So delirium can develop as a result of some medical conditions, including infections, febrile illness, metabolic disorders, head trauma, seizures, migraines, brain abscess, stroke, electrolyte imbalance, and others. People who are over age 65 are considered a high-risk group, and geriatric syndromes such as dementia, depression, falls, and elder abuse are often precipitating factors. There's also substance-induced delirium caused by intoxication or withdrawal from substances. This can be marijuana or alcohol or illicit drugs like cocaine and methamphetamines. Withdrawal from these can also cause symptoms. So it could be medication-induced or it could be withdrawal-induced. Also medications including anticholinergics, antihypertensives, and steroids can cause these types of behavior changes. The drug Chantix that people use to stop smoking can cause a delirium. And then also toxins can cause this, including lead, mercury, arsenic, and carbon monoxide. So the definition of a neurocognitive disorder is a condition where the cognitive function in a particular area of the brain is impaired, and those areas have to do with thinking, reasoning, memory, learning, and speech. Neurocognitive disorder can be classified as minor or major. It is important to pick up on when someone's having mild cognitive impairment because that's when we can do some interventions to either prevent or slow the progression of the disorder. There are more things that are being shown to be effective that we can do, such as alternative treatments rather than medications. At this point, none of the medications that we have are able to stop or cure the disorder, but they do slow down some progression. And some of those alternative treatments that we can do would include mindfulness and meditation techniques, for example. Major cognitive disorder is when there's very noticeable decrease in the ability to think, reason, and remember, and that's when we call it dementia. Dementias can be primary or secondary. Primary are the ones that are caused by some brain disease not directly related to any other organic disorder. And secondary neurocognitive disorders are those caused by or related to another disease or condition. So examples are, it could be from cerebral trauma, arteriosclerosis in the brain, or HIV disease, for example. Symptoms include impairment in abstract thinking, judgment, and impulse control. Social conduct rules may be disregarded. Behavior change that you see might be inappropriate, where you see someone doing something that they had done in their previous state of health that they never would have said or done that they're saying or doing now. Things like personal appearance and hygiene can be neglected. Language can be affected, or it may not be. Sometimes people don't speak at all and have aphasia, which is the inability to communicate. As the disease progresses, personality change is also very common. Some examples are when a person who is very socially active may all of a sudden become isolated. A neat person may become very untidy. People who had trusting relationships may all of a sudden be fearful and paranoid about the people that they used to trust. So reversible neurocognitive disorder, only a small percentage of cases fit into this, so it's not really a neurocognitive disorder as we usually think about it. So these are things like brain tumors, depression, side effects of medications, metabolic or nutritional problems. And once the underlying problem is taken care of, it goes away. So um, it's not exactly a neurocognitive disorder, but they do call it a reversible neurocognitive disorder when this happens. As a neurocognitive disease progresses, you may see aphasia, which is the inability to speak, apraxia, which is the inability to carry out motor activities, even though they might still have motor function, changes in mood, outbursts, inability to take care of themselves and their personal needs, wandering, and then incontinence. Wandering is very problematic. Every now and then you might see an elderly person who has wandered away either from home or from the nursing home and they get lost. It could be that the weather is bad and that they might also not understand how to dress for the weather. So it can be really a disastrous situation when this happens. Most cognitive disorders are Alzheimer's disorders. Between 60 and 80% of all cases are caused by Alzheimer's. There are stages of Alzheimer's. Stage 1 is when there's no apparent symptoms. There are changes that are starting to happen in the brain, but there's no decline in memory at this point. Stage 2 is very mild. A person may start to lose things or forget names. Short-term memory problems are fairly common. The person is aware that there's been a change and they might become very depressed or anxious about that, which makes the symptoms worse. They usually go to making lists or having structured routines to compensate for the memory loss. Usually other people aren't noticing yet, and it does not interfere with their ability to live or work independently at this time. Stage 3 is mild cognitive decline. This is when work performance is affected and it starts to become noticeable to others. They might get lost when they're driving, might have trouble concentrating, have trouble recalling names and words, and it might become noticeable to people that they're close to. Stage 4 is moderate cognitive decline. This is the place where they start forgetting major events in their personal history, such as their child's birthday. They're unable to perform tasks like shopping, cooking, and managing their own finances. They may not be able to understand what the current events of the world are. The person may deny that they have a problem or try to cover it up by confabulation, which is creating imaginary events to fill in the memory gaps. Depression and social withdrawal are very common at this stage. The person may need some assistance to be safe. In stage 5, people start losing their ability to perform everyday activities of daily living. They require assistance to manage these tasks, and they may forget addresses, phone numbers, and names. They may become disoriented to the place or time, but at this point they still maintain knowledge about themselves. Frustration, withdrawal, and self-absorption are very common. Stage 6 is severe. This is where people might not know the name of their spouse, and they might misidentify people. They can be disoriented to the surroundings, and the person might be unable to recall what day it is, what season it is, or what year it is. They are unable to manage without assistance. Delusions become apparent. Maybe they believe that they have to go to work even though they no longer have a job. Urinary and fecal incontinence are common. Sleeping becomes a problem. They may become agitated and possibly aggressive. Symptoms seem to worsen in the late afternoon and evening, and this is called sundowning. They may have problems with communication at this point where institutional care may be required. And stage 7 is a very severe decline. Here, the patient is unable to recognize family members. They're commonly bedfast and aphasic and immobile. So neurological disorders are differentiated by their etiology, although they share a common symptom presentation. Alzheimer's disease is characterized by the symptoms we just discussed and identified on the range of mild to major according to those 7 steps that we just discussed. Diagnostic criteria now enables clinicians to use CT scan or MRI to find degenerative pathology in the brain, which you can see as atrophy, widened cortical sulci, or enlarged cerebral ventricles. So there are some hypotheses about what causes neurocognitive disorders. Neurotransmitter alterations in the brain. So in patients with Alzheimer's, the enzyme that is required to produce acetylcholine is reduced. This decrease in acetylcholine reduces the amount of neurotransmitters that are released to the cells in the cortex and the hippocampus, resulting in disruption of the cognitive processes. The plaques and tangles, having an overabundance of these structures in the brain is thought to contribute to the destruction and death of neurons, which leads to memory failure, personality changes, and other features of the disease. Head trauma, so people who have had a history of a head trauma have an increased risk of Alzheimer's disease, and this head trauma may have occurred years before they ever develop dementia. And then genetic factors. There are some familial patterns with Alzheimer's disorders. There is now some testing that can be done to determine someone's likelihood of getting the disease prior to actually having symptoms themselves, if someone in your family has dementia. In vascular neurocognitive disorders, there is significant cerebrovascular disease, impaired blood flow in the brain, which then results in intellectual deterioration. Its difference from Alzheimer's is that it has a more abrupt onset and it runs a very variable course. Progression usually occurs in steps rather than a gradual deterioration. Causes of vascular neurocognitive disorder are directly related to interruptions of blood flow in the brain. Symptoms result because of death of nerve cells in the regions that don't get enough blood flow. Hypertension can damage the lining of blood vessels and can cause small hemorrhaging in the brain. This may cause things like mini strokes or silent strokes, cerebral emboli, and cerebral thrombosis. Another type of neurocognitive disorder is frontotemporal neurocognitive disorder. It was called Pick's disease in the past because there is shrinkage of the frontal and temporal anterior lobes of the brain. The cause is unknown, but it's believed that there is a genetic factor. Clinical patterns result in either behavioral and personality changes or language and speech problems. Traumatic brain injury is caused by an impact to the head or other mechanisms of rapid movement of displacing the brain within the skull, causing one of or more of the following: loss of consciousness, post-traumatic amnesia, disorientation, confusion, or other neurological signs. Amnesia is the most common following a head trauma. There may also be changes in speech, vision, and personality. The person may be emotionally labile. They may have very sudden changes in their behavior and mood. This impulsivity may be a cause of damage to themselves or others. Lewy body is a neurocognitive disorder similar to Alzheimer's disease. However, there tends to be a more rapid progression, and there's an earlier appearance of visual hallucinations and Parkinson-like features. Depression and delusions are also common symptoms in this population. The disease is progressive and irreversible and may account for as much as 25% of all neurocognitive disorders. Neurocognitive disorder is also observed in as much as 75% of patients with Parkinson's disease. In Parkinson's disease, there is a loss of nerve cells located in the substantia nigra, and dopamine activity is diminished, which results in involuntary muscle movements, slowness, and rigidity. Tremor in the upper extremities is often seen. Infection with HIV-1 can cause a syndrome called HIV-1 associative cognitive motor complex. So in the early stages of this disorder, there may be some neural psychiatric symptoms, some changes in a person's normal psychological presentation, severe cognitive changes, and changes in behavior and psychosis are not uncommon in the later stages of this disease. Neurocognitive disorder can also occur as the result of substance reactions, overdose, or abuse. Symptoms are consistent with major or mild neurocognitive disease and persist beyond the usual duration of intoxication and acute withdrawal. Substances that have been associated with the development of neurocognitive disorders include alcohol, sedatives, hypnotics, anxiolytics, and inhalants. Drugs that cause anticholinergic side effects and toxins such as lead and mercury have also been implicated. So there are many other medical conditions that can cause neurocognitive disorder. Some of these are hypothyroidism, hyperparathyroidism, pituitary insufficiency, uremia, encephalitis, brain tumor, pernicious anemia, thiamine deficiency, multiple sclerosis, pellagra, which is a vitamin B3 deficiency, uncontrolled epilepsy, cardiopulmonary insufficiency, fluid and electrolyte balances, central nervous system and systemic infections, and lupus. So patient and family education is very important. We want to teach them about the disease, what the possible causes are, what to expect, and what symptoms they may see. We need the family to understand that their loved one will not get better, that this is a progressive illness, and what they need to look for. When the patient is in the early stages, we can include them in the education of what they can expect. Teaching will include ways to keep the patient safe, how to maintain reality orientation for their loved one, providing assistance with activities of daily living, information about nutrition, talking about difficult behaviors and how to manage those, talking about medication administration, and then talking about hygiene and toileting. There may be need for supportive services such as financial and legal assistance, caregiver support groups, respite care, and home health care. So we want to make them aware of all the resources that are available. So medical treatment for delirium, the first step is to determine the underlying cause. And then we might need to focus on fluid and electrolyte status, hypoxia, anoxia, and diabetic problems if those are the causes. Staff members should remain with the patient at all times and monitor their behavior, provide reorientation and assurance, and the room should have a low level of stimuli. Some physicians prefer not to prescribe medications for patients with delirium, but there may be times when these agents are needed. So if somebody's having psychosis with agitation and aggression, they might need to have a chemical or mechanical restraint for their safety. Some antipsychotic agents can be used to relieve agitation and aggressions. Benzodiazepines are commonly used when the etiology is substance withdrawal. Once a definitive diagnosis of neurocognitive disorder has been made, the primary consideration for treatment is the etiology. So the focus must be directed on identifying and resolving potentially reversible causes. And knowing that things like Alzheimer's disease are not reversible, but there are medications that can slow the progression. So for Alzheimer's disease, the cholinesterase inhibitor phyostigmine has been shown to enhance functioning in individuals with mild and moderate Alzheimer's. Other cholinesterase inhibitors are being used to treat mild and moderate cognitive impairment in Alzheimer's disease and have been shown to have efficacy in treating patients with Lewy body dementia. There are some other medications that are being used that are listed here. Memantine was approved for the treatment of moderate to severe Alzheimer's disease, and in clinical trials, it has been shown to improve cognitive function and the ability to perform activities of daily living in patients with mild to severe Alzheimer's disease. So historically, physicians have prescribed antipsychotic medications to control the symptoms of agitation, aggression, hallucinations, thought disturbances, and wandering in patients with neurocognitive disorder. Atypical antipsychotics such as Risperdal, Zyprexa, Seroquel, and Geodon have been used because they have less anticholinergic and extrapyramidal side effects. However, there is a black box warning on using atypical antipsychotics in elderly patients. It has shown to have an increased risk of death and is very risky to use in this patient population. Antidepressant medications are sometimes used to treat depression and neurocognitive disorder. SSRIs are considered to be the first-line drug treatment for depression in the elderly because they do have a favorable side effect profile. Some physicians do still use the tricyclic antidepressants, but they do have significant cardiac and anticholinergic side effects, so they're used pretty cautiously. Trazodone may be a good choice, used at bedtime for depression and insomnia, and dopaminergic agents may be helpful to treat severe apathy. Anti-anxiety medications may be helpful, but should not be used routinely or for prolonged periods of time. The least toxic and most effective of the anti-anxiety medications are the benzodiazepines. The benzos with the shorter half-lives, such as lorazepam and oxazepam, are preferred to those with longer acting half-lives, such as diazepam. And the reason for that is the longer acting ones lead to a higher risk of oversedation and falls in this patient population. Sleep problems are common in patients with neurocognitive disorder and may intensify as the disease progresses. Sleep disturbances are among the problems that most frequently initiate the need for placement of the patient going to a long-term care facility. Some physicians treat sleep problems with sedative hypnotic medications. The benzos may be useful for some patients, but are indicated for relatively brief periods only. So again, remembering that the benzos are those that end in PAM or LAM. So on your list here, it's the first three. Daytime sedation and cognitive impairment, in addition to paradoxical agitation in elderly patients, are of particular concern with these medications. The non-benzodiazepine sedative hypnotics are also used, such as Ambien, Sonata, and Lunesta, and antidepressants like trazodone and Remeron are also prescribed. Daytime sedation may be a problem with these medications. As previously stated, barbiturates should not be used in elderly patients.